Today we will discuss about the hypophysitis. So what is hypophysitis? It is usually umbrella term that covers a broad range of inflammatory disorders that affect the pituitary gland. So hypophysitis is basically can be categorized in three types, that is adenohypophysitis, infundibular neurohypophysitis and panhypophysitis. So we will discuss in great detail. Further classification like what is primary hypophysitis and secondary hypophysitis. In primary hypophysitis, it is an isolated condition which includes autoimmune conditions such as lymphocytic hypophysitis and other inflammatory and infiltrative forms of isolated pituitary involvement of unknown causes. Secondary hypophysitis is secondary to a reaction to a local process, example rupture of Rathke's cleft cyst, systemic disease, infection, or neoplastic processes or drugs. Histologically, it can be classified in lymphocytic, which is the most common, granulomatous, xanthomatous, IgG4 related, necrotizing, and mixed forms, that is lymphogranulomatous and xanthogranulomatous forms. Among the clinical presentation symptoms related to the pituitary deficiencies, that or plus minus headache and vision changes related to the mass effect. Approximately half of patients with primary hypophysitis present with the headaches. Around 10 to 30% present with the visual disturbances related to the mass effect. Symptoms related to the loss of anterior or posterior pituitary hormones depend on the etiology and extent of the pituitary damage. Also, there is a presence of both anterior pituitary dysfunction and DI in case of inflammatory and infiltrative process, craniopharyngioma and metastasis, and it indicates highly unlikely in case of pituitary adenoma. So, involvement of both, that is anterior and posterior pituitary in form of DI, is unlikely in case of pituitary adenoma. There, in case of lymphocytic hypophysitis, and that is something related to immunosuppressive therapy induced hypophysitis, inflammatory process predominantly affects the corticotropes followed by the gonadotropes and thyrotropes. In case of pituitary adenomas, corticotropes are usually affected last. Among the radiological features, the most frequent MRI finding is the thickened, non-deviated stalk, which can be isolated, that is infundibular neurohypophysitis, in one-third of patients, or associated with mild to moderate symmetric gland enlargement in more than 80% of patients. Contrast uptake is usually intense, homogeneous, and less frequently heterogeneous. An enlarged pituitary resembles a pituitary macroadenoma in approximately half of patients with primary hypophysitis, and cellular floor is usually intact in case of hypophysitis. Other signs are the loss of posterior pituitary bright spot caused by depletion in the vasopressin granules in the posterior pituitary. Others are the dural inflammation may cause a dural tail sign similar to that observed in patients with a meningioma. In late disease stages, the pituitary gland may appear atrophic, and MRI may show the cellular arachidonocele or an empty cellar. No definite MRI features that can confirm the hypophysitis. Imaging can be diagnostic in the right clinical context. So these are the few examples. So it is heterogeneous hyperintensity on the T2 weighted sagittal image and isointensity on the T1 weighted sagittal image. Here we can see, and here we can find out that this is a heterogeneous hyperintensity on T2 weighted sagittal image. Here we can find that, and that we have already discussed, that is isointensity on T1 weighted sagittal image, homogeneously enhancing gland and stalk thickening in case of the post contrast T1 weighted image, and empty cella occurs in the late stages. So here we can find the heterogeneous hyperintensity two weighted coronal image and isointensity on the T1 weighted coronal image and homogeneous contrast enhancement uh, on the post contrast T1 weighted coronal and both sagittal images. So it shows the enlarged pituitary gland shows the heterogeneous hyperintensity on T2 weighted coronal image and hypointensity on the T1 weighted coronal image with peripheral enhancement and loss of the central enhancement. So here we can see these things. In case that is showing the post contrast T1 weighted images shows an enlarged pituitary gland with central non-enhancing components and peripheral contrast enhancement. So here we can find that. Here we can find that there is a peripheral post contrast T1. In case of T1 weighted image there is a enhancement, whereas in case center there is a non-enhancing component, further showing enlarged pituitary gland and stalk showing homogeneous hyperintensity on the T2 and T1 weighted coronal images with an absence of central contrast enhancement and strong peripheral enhancement. So these are the differentials among the differential diagnosis, the cellular and supracellular tumors, that is craniopharyngioma, germinoma, astrocytoma, meningioma and others. These can also be secondary causes of hypophysitis. Others are the physiological pituitary hypertrophy and mets mostly frequently from the lung, breast, prostate and kidney, and further the pituitary apoplexy can also present like that. So these are the clinical features corresponding to these, and one thing we should notice that among the physiological pituitary hypertrophy, there is a homogeneous gland enlargement, usually absent headache, no panhypopituitarism. Underlying cause is severe primary gland insufficiency, that is gonadotroph hyperplasia of the menopause, thyrotroph hyperplasia in severe untreated primary hypothyroidism, and somatotroph hyperplasia of the adolescence, lectotroph hyperplasia of the pregnancy. And these are the things we should keep in mind always as a differential diagnosis. Others are the acute Sheehan syndrome. Others are the lymphoproliferative malignancy, plasmacytoma, and lymphoma. These are the characteristic features associated with this, and this is the characteristic feature associated with the lymphoproliferative malignancy, plasmacytoma, or lymphoma. These are the radiological scores which are there to differentiate, try to differentiate between the hypophysitis and the pituitary adenoma. So in that age, if less than 30 years, it is more indicative of the hypophysitis. In relation to pregnancy, more towards hypophysitis. Pituitary volume is more than 6 centimeter is more towards pituitary adenoma. Gadolinium enhancement features, that is heterogeneous, it is more towards the pituitary. That is enhancement is type is medium or high is more towards the that is hypophysitis, and if it is a heterogeneous enhancement, that is more towards the pituitary adenoma. If it is a symmetric, regarding the symmetry, if it is asymmetric, more towards pituitary adenoma. If posterior pituitary bright spot is lost, that is more towards the hypophysitis. If stalk is enlarged, more towards the hypophysitis. If mucosal thickening is there, that is more towards the pituitary adenoma. So these are just the scoring systems which you actually helps us to predict whether it is more towards the hypophysitis or more towards the pituitary adenoma. What is the role of biopsy? Biopsy establishes hypophysitis histopathological type and rules out other etiologies. Usually considered either when a diagnosis is unclear after the initial investigations or when pathology results are needed for the treatment. No established criteria for pituitary biopsy in adults. In one of the UK consensus, they proposed that if there is an unclear diagnosis after extensive lab imaging and CSF investigations, when stalk thickening is more than or equal to 6.5 centimeter, when there is a clinical deterioration defined as worsening of the hormonal dysfunction, structural disease, or visual disturbances. So the UK consensus have actually proposed biopsy in these scenarios. How to evaluate? The baseline workup in form of these investigations, that is CBCSR, CRP, calcium, creatinine, urine analysis, and ALT. Specific investigations further tailored to the clinical features like IgG4, acetylcholinesterase, ANCA, ANA, LDH, beta-2 microglobulin, alpha-fetoprotein, human chorionic gonadotropin, tuberculin skin test. Others are the whole body CT and PET CT to rule out other affected sites in systemic disease including sarcoidosis, TB, granulomatous polyangiitis, malignancy, and IgG4 related disease. Whole body imaging is recommended in patients with isolated stalk lesions and no lymphocytic hypophysitis clinical context or when the malignancy or infiltrative disease is highly suspected. Further in CSF analysis in form of cytology, flow cytometry, and immunochemistry, including ACE levels, SCG, and AFP, and further CSF culture, helpful if initial investigations are negative, a neoplastic process or infections are suspected, as well as in evolving disease. If all these investigations are negative, a trial of empiric high-dose glucocorticoids could be considered, as most of the infiltrative and inflammatory conditions will have similar treatment, that is high-dose glucocorticoids and or immunosuppression. Biopsy to be reconsidered in patients with unfavorable clinical course. Biopsy confirmed diagnosis would allow the selection of appropriate therapy and avoid delays in treatment of other diseases. Among the treatment, glucocorticoids have been considered the mainstay of treatment for primary hypophysitis that target the inflammatory process. One of the cohorts in Germany in that the 46% of patients with primary hypophysitis managed by observation only showed radiological improvement and one-third had hormonal recovery, mainly vasopressin and ACTH. In the chronic phase, when irreversible changes have occurred, anti-inflammatory treatment may not affect the radiological or hormonal outcome. No RCTs, unclear if glucocorticoids allow for the better pituitary function recovery versus simple observation. Weigh the risk or versus benefits before considering the glucocorticoids. So observation may be safely considered in case of mild to moderate headache, mild pituitary dysfunction, no mass effect on the optic chiasm, probable lymphocytic hypophysitis. Initial clinical surveillance can be performed with pituitary MRI at 3 to 6 months. Interval can be prolonged if disease evolution is favorable. So during the observation, periodic re-evaluation for pituitary function recovery is needed. Clinicians should be alert for the new symptoms affecting other organs as systemic disorders. If lesions are causing a significant mass affected baseline or follow-up, either glucocorticoid treatment, biopsy, or both should be performed. Primary hypophysitis has very variable glucocorticoid response rate, from 20% to more than 95% in a partial or complete hormonal and radiological response. Overall improvement in endocrine functions occurs less than reduction in the pituitary mass, which can attain closer to a 75% response rate. Earlier glucocorticoid initiation has been shown to improve the hormonal recovery. So continuing from our last session on hypophysitis, so the dosage of prednisone may vary widely from around 20 mg per day to even up to 1 gram methylprednisolone pulse therapy. Intravenous pulse followed by high-dose prednisone resulted in a twofold hormone recovery rate compared to the patients with observation. Even low glucocorticoid doses may also be effective. Sometimes immunosuppression with rituximab, azathioprine, or methotrexate may be considered in glucocorticoid refractory cases and as glucocorticoid-sparing options. Azathioprine is the most studied and appears superior for the mass reduction than hormonal improvement. Similar results with methotrexate and MMF have been found. Rituximab can be used in B lymphocyte predominant diseases and relapsing IgG4 related disease, and complete remission is sometimes possible. Surgery in cases of those hypophysitis where decompression of optic chiasm, confirmation of diagnosis in glucocorticoid resistant cases, surgery may be required. Others like fractionated radiotherapy and stereotactic radiosurgery have been used successfully in a few patients requiring multimodal therapy. When there is a clinical suspicion of hypophysitis, careful history and clinical examination. If it is immunotherapy active or recent, then immunotherapy induced hypophysitis, and we will see in further slides how to treat. If it is a young female with recent or active pregnancy, thyroid or other autoimmune disease, then probable lymphocytic hypophysitis, we will discuss this also. If there are known secondary causes like sarcoidosis, pneumomatous polyangiitis, Langerhans histiocytosis, infection and others, then we will assess accordingly and treat accordingly. If we are suspect IgG4 related disease, then we will look in further slides. And as similarly, if there is a high suspicion of malignancy or meds, or as we will treat accordingly. So in cases of if there is an anterior hypopituitarism or DI, hormone replacement has to be done obviously. Further, on clinical examination, if there is a headache and vision change is there, then MRI might show enlarged gland, homogeneous enhancement, stalk thickening, and loss of the posterior pituitary bright spot. Additional workup will be according to case basis based on the history, examination, and clinical suspicion, that is CBCSR, CRP, calcium, creatinine, urine analysis, ALT, IgG4 levels, ACE levels, ANCA, ANA levels, beta-2 microglobulin, AFP, beta HCG, and TB test. Others to look for like chest X-ray, thoracoabdominal CT, skeletal survey, whole body, FDG PET, CSF cytology, AFP, beta SCG, ACE, oligoclonal bands, immunofixation, pituitary or other sites to be done. So we will discuss in further slides how to treat all these conditions. Specific types, lymphocytic hypophysitis, it is 2/3 of the total cases of primary hypophysitis, more in females. And in women, it occurs peripartum in more than half, either in late pregnancy or early postpartum, with a peak occurrence during the T3 trimester, third trimester. It's associated with a personal family history of autoimmune disease, that is autoimmune thyroid disease, lupus, primary biliary cirrhosis, celiac disease, among others, is frequent. Specific human leukocyte antigen DQ8 and DR3 alleles are predisposing. Here we can find that there is a lymphocytic infiltration, plasma cells and histiocytes and fibrosis. It is a T cell mediated event. CD4 plus T cells predominate and harbor a specific phenotype with T helper 17 and 1 cells, respectively, producing interleukin 17 and interferon gamma. In cases of severe headache and significant mass effect, high dose glucocorticoids are the first line treatment. Glucocorticoid response does not confirm a presumptive diagnosis of lymphocytic hypophysitis. Even secondary mass like inflammation due to a local or systemic mass process may also might respond to the high dose of glucocorticoids. Other is granulomatous hypophysitis, which is 20% of primary hypophysitis, more case in seen in females. Usually it is in the fourth decade of life. Several series have shown more severity with more frequent headaches, higher rates of anterior hypopituitarism, diabetes insipidus up to 75%, and degree of radiographic abnormality, less glucocorticoid responsive compared to the lymphocytic hypophysitis. So there are multinucleated giant cells, histiocytes, lymphocytes, and granulomas. Other secondary causes could be may not always manifest with the multisystem involvement, that is sarcoidosis. Others we have to look for the ACE in the CSF, which is approximately found in 50% of cases. Hypogonadism was the most frequent axis affected, and DI was also present in half of cases. Pituitary MRI changes include a hypothalamic pituitary stalk thickening in almost all cases, which regress upon the glucocorticoid treatment. Hormonal abnormalities persist long term. Others are granulomatous polyangiitis. It is a rare and usually found in association with multisystem disease. Pituitary involvement as an initial presentation may be noted in almost half of cases. Young females are more at risk. DI is almost universally present. First line treatment is glucocorticoids. Other immunosuppressive agents like cyclophosphamide can also be tried. Pituitary tuberculoma is a rare presentation of tuberculosis. Primary pituitary involvement can occur without multisystem involvement. The patients are usually afebrile with headache, visual impairment, hypopituitarism with DI. Caseating and necrotizing granulomas, AFPZ stains are usually negative in pituitary TB, but PCR for Mycobacterium and CSF can confirm the diagnosis. So, in one of the cohorts, there was much more prevalence of tuberculosis, and they were actually none of them were associated with the miliary disease. Histiocytosis is basically the originating from the abnormal Langerhans cells, and there is a hypothalamic pituitary involvement, more so in case of that is Langerhans cell histiocytosis more than the Erdheim-Chester disease. And infiltration preferentially affects neurohypophysis. DI will obviously present as the most common feature. LCH most often encountered in children but can also occur during adulthood. Bone, skin, cardiovascular, respiratory, polyadenopathy, and hepatosplenomegaly and other systemic features. Histopath will show CD1A, CD207 positive monoclonal Langerhans cells, and whereas ECD will show histiocytes with CD68 plus and CD1A minus. DI and growth abnormalities are the most common, as it is followed by hypogonadism, ACTH and TSH abnormalities. Some may present with hypothalamic dysfunction, hyperphagia, adipsia, impaired thermoregulation, sleep, memory, and behavioral disturbances. Treatment modality includes surgery, glucocorticoids, immunosuppressive agents, chemotherapy, radiotherapy, and the targeted agents. That is BRAF inhibitors and MEK inhibitors. IgG4 related disease, if in that there are more than 10 high powerful IgG4 positive plasma cells, storiform fibrosis, plasma cell hypophysitis that may present either as an isolated pituitary lesion, sometimes classified as primary hypophysitis or as a multisystem disease, characterized by dense infiltration of the lymphocytes and IgG4 positive plasma cytes, leading to fibrosis with characteristic cartwheel pattern in the advanced stages. IgG4 related disease may affect a wide range of organs, leading to a spectrum of clinical manifestation: retroperitoneal fibrosis, sclerosing cell adenitis, adenopathy, and pancreatitis; lung interstitial infiltration, pericardial and vascular fibrosis, nephritis, or renal thyroiditis. In a few reviews, among 52 idiopathic hypophysitis cases, 30 to 40% were confirmed positive involvement with IgG4 related disease. Mean age is 55 to 65 years. Males are more frequently affected. And yeah, the pituitary involvement in the IgG4 related disease affects 4 to 5% of patients. Sole presenting feature in around 10 to 30% of those, mostly in women. The vast majority will have multi-organ involvement, and FDG PET scanning variable multi-system hyperfunctional lesions. Histological criteria are obviously required. Even compatible MRI findings combined with other tissue biopsy prove one disease. Elevated IgG4 levels, that is more than 140 mg per deciliter, and a good response to the glucocorticoid treatment. Combined antipituitary deficiency with DI is observed in 20 to 40% of cases. In more than half of the patients, both pituitary and stalk are enlarged on imaging. 15 to 25% patients will have normal IgG4 levels, mostly women. Response to supraphysiological glucocorticoid dosage is universal and may prevent fibrosis. Prednisone at dose of 30 to 40 mg per day is usually given for 1 to 2 months and then tapered over 2 to 6 months. Relapses are infrequent and rituximab might be a good alternative in these cases. Other less common is the xanthomatous hypophysitis, and there is an infiltration of foamy histiocytes without granuloma formation with fibrosis in the chronic phase. Some cases giant cell reaction, xanthoglomerular hypophysitis in association with Rathke's cleft cyst, leakage, rupture, and hemorrhage. CD868 positive foamy macrophage, cholesterol clefts, hemosiderin deposits. Xanthomatous hypophysitis, average age is 34 years, 90 male, female predominance is there. Symptoms resemble those of mild lymphocytic hypophysitis, and optic tract related symptoms have been infrequently reported. Less responsive to corticosteroid therapy and endocrine dysfunctions tend to be difficult to ameliorate. MRI shows cystic components and peripheral contrast enhancement is observed. The cystic components correspond to a dark orange fluid-filled cyst with suspended crystals seen macroscopically. Other less common is necrotizing hypophysitis, in which there is a diffuse non-hemorrhagic necrosis with surrounding lymphocytes, plasma cells, and eosinophils. There is an acute onset headache with anterior or panhypopituitarism, and hormone replacement is generally required. There is extensive necrosis, lymphocyte and plasmacyte few eosinophils. MRI shows diffusely in last pituitary gland and infundibulum with a typical loss of central contrast enhancement. Other is immunotherapy related hypophysitis. These molecules inhibit the self-tolerance and tumoral immune escape, that is T cell activation, enhance host immunological response towards the cancer cells. The immune related events occur as side effects and can affect multiple organs and systems, including the pituitary. So, what is the mechanism of immune checkpoint inhibitor therapy? Actually, immune checkpoint inhibitors inhibit the interaction between the antigen presenting cells and the T cells. So, it further leads to the T cell activation and proliferation. So, ICIs actually reactivate the immune response of the host. They do not directly attack the tumor cells. So here we can see that finally leading to the cytotoxic effect by the T cells, and this leading to the hypophysitis with multiple hormone deficiencies. Mechanisms for the immunotherapy related hypophysitis include autoantibodies directed to the pituitary and complement activation, that is type 2 hypersensitivity reaction with CTLA4 inhibitor. CTLA4 is also expressed by the pituitary cells, thus making it a direct target for these drugs. In a series of 8 patients who developed immunotherapy-related hypophysitis, 2 autoantibodies were significantly associated with hypophysitis. One targets integral membrane protein 2B, a protein implicated in ACTH stimulation and release. Second targets guanine nucleotide binding protein G, subunit alpha, implicated in hormone synthesis, notably TSH. Not all immunotherapy drugs have the same effect on pituitary gland. A comprehensive cohort analysis on checkpoint inhibitors showed a different profile of PD1, PDL1 inhibitors compared to the CTLA4. Lower incidence, milder course development later during the treatment, isolated adrenal insufficiency, less headaches, and rare MRI changes. However, combined anti-CTLA4 and anti-PD1 or PDL1 therapies lead to an increased occurrence and earlier disease. ACTH is the most frequent deficit in all checkpoint inhibitors, usually isolated in PD1, PDL1, and may be associated with TSH and LH-FSH deficit in CTLA4 inhibitor treated patients. Very rarely, hyperprolactinemia DI will occur. DI is atypical and may suggest a pituitary metastasis. The role of imaging diagnosis is less clear, mostly used to exclude other causes of hypopituitarism. Pituitary MRI changes can be either subtle or even absent with anti-PDL1 and PD1 inhibitor therapy, although MRI may reveal pituitary gland hypertrophy with CTLA4 inhibitor therapy. MRI changes can precede the hypopituitarism development. In patients undergoing brain imaging surveillance for the primary metastatic cancer, close attention to the pituitary gland is needed. Risk factors for the immunotherapy-induced hypophysitis are the male sex, older age, and possibly higher doses of the culprit drug. No specific predictors. Clinical assessment and regular adrenal and thyroid monitoring should be planned at least monthly during the first 6 months and extended thereafter as needed. Cortisol axis evaluation can be challenging in patients who have received high-dose glucocorticoids and or have dysalbuminemia or acute illness. As primary adrenal insufficiency has also been described, much rarer obtaining ACTH levels is important. Patients should be educated about the symptoms of adrenal insufficiency, although non-specific. Awareness throughout and after treatment advised, as some delayed events have been described, occurring even up to 6 to 15 months after the therapy cessation. Physiological hormone replacement needs to be done. Delayed immunosuppressive therapy might be reasonable in the acute setting until patient is stabilized, but discontinuation does not improve the pituitary outcome and may lead to the cancer progression. High-dose glucocorticoids should be restricted to patients with severe symptoms of mass effect, visual loss, retinal crisis. In those patients with melanoma, use of high-dose glucocorticoids has not been shown to improve the pituitary recovery. Experiencing an immune-related event seems to confer a better overall survival compared to the patients without such events. The adrenal axis rarely recovers in these patients, but gonadal and thyroid may, and they should be reassessed periodically. So it is very important that adrenal axis rarely recovers in these patients, but gonadal and thyroid axis may, they should be reassessed periodically. Paraneoplastic pituitary autoimmunity, tumors that express PIT1 or pro-opiomelanocortin ACTH may lead to production of anti-PIT1 and anti-ACTH antibodies. Anti-PIT1 syndrome leads to a combined deficit in growth hormone, prolactin, and TSH. Other tumors may trigger anti-TSH antibody production that leads to immune destruction of corticotropes and subsequent adrenal insufficiency. PIT1 hypophysitis has been observed mostly in patients with thymomas and other malignancies such as lymphoma. Isolated ACTH deficiency observed in the gastric cancer, lymphoma, and ACTH expressing large cell neuroendocrine carcinoma. Histologically is not well described. However, on autopsy, pituitary lymphocytic infiltration was found in patients with an ACTH expressing large cell neuroendocrine carcinoma. Clinical presentation is a hormonal deficiency without headache and may precede a diagnosis of underlying cancer for a few years. Imaging is often unremarkable or reveal mild pituitary atrophy or heterogeneous gland enhancement. Hypopituitarism is irreversible and treatment relies on management of the underlying cancer and the hormone replacement. Thank you.